Okay, so sorry I'm late. So we'll talk a little bit about wearing off and what those signs and symptoms are and how we treat them. In fact, that last patient I was seeing this morning was a patient where the spouse was saying, hey, I think, I'm using these RightRe capsules, but I think some of them are empty because I give them to my wife and it doesn't work. So she has what we can call a delayed on or a no effect on the medicines. And the reason that happens, so remember that Parkinson's affects all of the muscles of your body, including the muscles of the gut. Everything slows down, including the gut. And that's the reason why you have constipation. So because the gut has slowed, more fluid gets sucked out of the stool gets hard and you get constipated. Once you're constipated, that gastrocolic reflex doesn't work. So, how it should work is that you swallow something, you're going to eat lunch, swallow a meal, and then that stomach tells the colon, hey, we've got stomach that we're, food that we're digesting here. We need to move things along. You need to have a bowel movement so I can move everything along and we can absorb it. But if you're constipated and if you have gastroparesis or a slow gut, everything sits in the stomach and nothing moves into the small intestine. And that's actually where your medications are absorbed. They're absorbed in the small intestine. So if you're constipated, you take a dose of the medicine and it sits and sits and sits, and it may take 90 minutes to kick in. So that's what delayed on is. And that's one of the biggest reasons with our oral medications with Parkinson's is that 90% of our medicines are oral. And that's what gives us the most trouble with Parkinson's, the on and the off, the dyskinesia. And so one of the ways to combat that is to, one, make sure that you're treating the constipation, so everything's flowing through the gut on a reasonable time scale so that your meds are working more efficiently. And then sometimes we use other medicines like rotigotine or the Nupro patch that goes through the skin, so we bypass a slow gut. Or we can use the inhaled version of levodopa and Brady, and we go through the lungs. We go lungs to brain instead of gut to brain. So we're bypassing that slow gut. Or we can use longer acting forms of levodopa so that we only need to get into the small intestine 3 or 4 times a day instead of every 2 hours. So we can use RightRe, which is a longer acting form of levodopa. Or for patients who are taking, levodopa more than 5 times a day, 6 times a day, and they're having a lot of on and off, then we can use Duopa, which is a pump that uses a levodopa gel that goes straight into the small intestine, so that we bypass that slowed gut or that gastroparesis, and that every 57 seconds you're getting a dose of levodopa, and so you're on most of the time. So in Parkinson's, when you're off, most patients talk about their off symptoms as motor symptoms. So the medicine wears off and you have a tremor, or you have rigidity or stiffness. And so you have those motor symptoms, bradykinesia, or that slowness of movement. But you can also have non-motor symptoms of PD when you wear off. And many times that's the very first sign of wearing off, is that you can have numbness or tingling in the hands or the feet, or that your big toe goes up and the toes curl under, or you could have anxiety. So I have a patient again this morning his first sign of wearing off is actually anxiety and lots of nausea. So usually patients get nausea when they take their dose of medicine. They take a dose of levodopa and that makes them super nauseous. But some patients get nausea with anxiety. And so his nausea is actually due to wearing off, the off period, and having the anxiety from that off period. And so you can even have a frank panic attack during your off periods. And then the fix for that is not to give you more Xanax, it's to give you more levodopa, more dopamine, so that you don't have the off periods. And it's important to recognize both your motor and non-motor symptoms of off, because the earlier you pick up your off symptoms, then the earlier you can dose yourself. So because let's say you're on an 8, 12, 4, and 8 schedule, and you did, rock steady boxing, or you did physiotherapy, and instead of your medicines lasting until 12, you wore off at 11. And you say, oh, well, my schedule's not until 12. I'm going to wait until 12 o'clock to take my next dose. Once you're off, then it takes longer for that next dose to kick in, because remember, that pill is staying in the stomach. So that you want to recognize your off period. And if you wear off at 11, whether that's numbness, tingling, or anxiety, you want to dose at 11, because that way your medicine doesn't take so long to kick in. remember, we're treating you, the patient, not the clock. The clock doesn't have Parkinson's, the patient has Parkinson's. And your levodopa, it's like gas in the car. So if you drive your car at 80 miles an hour, it uses up more gas than if you drive at 50 miles an hour. And that's why you notice that some days your medicine lasts longer than others. So some days when you're just sitting at home watching the ball game, it lasts 3 to 4 hours, no problem. But if you're doing physical therapy or rock steady boxing or you're stressed, you have to pay taxes, then it lasts only 2 to 3 hours. And that's the difference. I've been talking a lot. So any questions that you guys have? And just like you can have bradykinesia, which means slowness of movement, you can have Brady which means slowness of thinking, and that's also an off-period symptom. So that many times it's not the patient who notices the first sign of wearing off, it's the spouse who says, hey, I'm talking to them, but they're just not, getting it. It takes too long to process the information. And that could be the first sign of wearing off.
So everyone, I think, Ken, you have a question. So now we had everyone in auto mute, so we wouldn't interrupt, but now we're gonna go for it. And I think, Ken, you're up first. Let's hear your question.
You've mentioned carbidopa, levodopa, and dopamine.
Yeah. Mm-hmm.
Would you please clarify those three terms?
Sure. So, what happens in Parkinson's disease is that there's cells deep in the brain that produce dopamine, which helps you with movement. And then as you lose those dopamine producing cells, we have to replace that dopamine with the medication. So the gold standard for Parkinson's is still carbidopa levodopa. That levodopa turns into dopamine in the brain. And that carbidopa is there to help you with the nausea and to help most of that levodopa, more of it to get into the brain. So when we say dopamine, levodopa, it's the same, it's interchangeable. You're making your own dopamine, and then we're replacing the dopamine with your medication. The Sinemet, which is carbidopa levodopa, that's your yellow Sinemet. Then there's Sinemet CR, or extended release, and then there's RightRe, which is a capsule that has immediate release and extended release carbidopa levodopa in a capsule.
Right. I take RightRe.
Yep.
And but so you're saying that, because this has always bugged me, so I'm glad you're explaining this. You said that levodopa converts to dopamine?
Yes.
Okay. And carbidopa just helps with some of the side effects of taking carbidopa?
So the reason that Sinemet or carbidopa levodopa is still the gold standard for the treatment of Parkinson's disease is that levodopa turns into dopamine, exactly the same chemical that's missing. Whereas things like Mirapex, Requip, they go and they sit on the same receptors as dopamine, but chemically they're not the same chemical. And the carbidopa is in there so that you tolerate the levodopa better. So if we just gave you straight levodopa, it would make you nauseous, you would be vomiting, and most of that medicine would not get into the brain. So if we give you some carbidopa, you have less nausea, and it doesn't metabolize all in the liver, and more of it makes it up into the brain.
And why don't we take dopamine directly?
Because we need to pass the blood-brain barrier. So we need you to swallow it. So levodopa, the dopamine is a very large molecule and it doesn't fit on a patch like rotigotine or Nupro does. And it's the reason why we can't just give you a once a day dopamine. It just doesn't work. The metabolism doesn't work. So we end up taking it every couple of hours because we have to cross the blood-brain barrier.
And taking, let's say oral or injectable dopamine would not cross that barrier.
Right. So there's a apomorphine, which is a dopamine agonist that you can take as Apokin, an injection. So a sub-Q injection, that's a rescue medicine. And hopefully next year we're going to have an apomorphine pump so that you can have, a continuous sort of dopamine tone with apomorphine, which is a dopamine agonist. It's not the same chemical, but it goes and it sits on the same receptors as dopamine. And it gives you more continuous infusion. So remember, the normal brain gives you continuous infusion of dopamine over the 24-hour period. It doesn't pulse you with dopamine every 3 to 4 hours the way the oral medications do. The reason that we're pulsing, because we're pulsing the brain every 3 to 4 hours, we get all of the problems of Parkinson's, the on and off, the on time with dyskinesia. So the more we can smooth that line out, the better we have you working like the normal brain. Does that make sense? I mean, it's
until you said normal brain, that keeps me out right there.
Yeah, I know. So because it's the reason why your doctor, you always think, gosh, my doctor's always picking the most expensive medicine on the market. And we're not picking the most expensive medicine, we're just picking the longest acting form of your medicine so that we don't peak and trough so many times during the day. So if we can use a once-a-day dopamine agonist like Mirapex ER, we rather use that than the 3 times a day one. If we can use RightRe, which has, a longer, it's a 4 to 6 hour half-life, then we rather do that than yellow cinnamon, which only lasts 90 minutes or up to 3 hours if you're still able to absorb it. So it's the reason why you always think, gosh, you're always picking these expensive medicines, but we're picking medicines that are working more like the normal brain.
Great, thank you very much.
Sure. Mm-hmm. What other questions?
I think Debbie Shapiro is next in the queue. Debbie, are you out there? Do you want to ask your question?
Yes, I do. I always thought that when we exercise, we form dopamine in our brain. So why would that cause us to have an earlier off rather than be sedentary?
Yeah. So exercise, you remember we have those cells, that produce dopamine, and in Parkinson's, you're losing those cells. And by the time you see a neurologist, you've already lost 60% of those cells have already died off. So you've already had PD, 10, 15 years. What exercise does, and specifically aerobic exercise, the one that gets the heart rate up, it gets those cells to make new connections. The more connected they are, the more robust and healthy they are. The longer they live, the slower the progression of your PD. So, and the exercise generates something called BDNF, or this brain-derived nerve growth factor that makes them feel better. It's like Gatorade for the brain cells. So in that sense, it makes your brain feel better. But your dopamine, your levodopa, it's like gas in the car. So the faster you go, the more you're going to use it up. And that's both physically and emotionally. Remember that Parkinson's disease is the poster child for the mind-body connection. Everything that you're thinking, feeling gets reflected in the Parkinson's disease. The more anxious or stressed you are, the more tremor comes out, the more dyskinesia comes out, the more freezing of gait you can have. And so that's why patients notice that some days the medicines last longer than others. That all has to do with what they're doing, how they're feeling, what they ate, how they slept. And it's important to realize that we're treating your body, not the clock. So the clock's on the 8, 12, 4, and 8 schedule, but the clock didn't go to do rock steady boxing and didn't wear off at 11. And so if you wear off at 11 and you wait until 12 to take your next dose of levodopa, it's going to take that much longer to kick in because it's sitting in the stomach and it needs to get into the small intestine to get absorbed. So that the very first sign of wearing off, whether that's a tremor or rigidity or stiffness, or you have that numbness and tingling, or you feel anxious or depressed, that's when we want to take that next dose, because the earlier you take it, the faster it kicks in and the less off time you have. That's why if we're using once-a-day medicines or longer acting forms of the medicine, then we don't have to worry about getting into the small intestine so many times during the day.
What I find happens is that when I exercise, I have like a surge of dopamine natural in my brain.
Yeah.
And then as soon as I stop, it's like I go way down very, very quickly.
Right. So many patients have a little bit of extra dose or dose early before their exercise regimen, or they dose early right after. They don't wait until, let's say their next dose is at 12, but they wore out, they finished exercising at 11, they dose it early.
Right. I got you. Okay. Thank you.
Mm-hmm.
Thanks, Debbie. And you're joining us from the other side of the world, right? There you are.
Okay, from Jerusalem, Israel.
Oh, okay. Nice.
Far away.
Far away.
much.
I'm
Okay.
after supper, not lunch.
Oh,
I said,
Right,
"You're having lunch. I'm after supper."
right.
at least it's not midnight snack with docs.
Exactly right.
Well, I think we have Lori and Tom in the queue. So I'll go with Tom next. Tom, go ahead with your question.
Yeah, I had a question. Can you hear me?
Yes.
My wife has DBS. They had it installed on April of 2018, and she's always been on Namebrand Cinnamon since 2008. And then in February of 2019, Merck stopped making the Namebrand. We had to go to generic Carbidopa. And the potency of a generic is not as good or as strong as a Namebrand. So they've had to increase their medication, because I guess a lot of people don't realize that you don't get the same amount of effect with a generic as you do a Namebrand.
Yeah, so that's true. So the generics only have to have 80% efficacy.
All right.
100%. And so many patients notice that, and it's more of a problem for epilepsy patients, where now if their epilepsy medicine only works 80% of the time, they could have a breakthrough seizure, lose their license for another 6 months. So that in those cases, we always want to keep them on branded medicine. Many times also there's different fillers in the generic medicines, and sometimes patients are allergic to those fillers, so they develop a rash. But Merck decided no longer to make Sinemet CR, and so there's only generic manufacturers. But I mean, now we can switch you to RightRe, which has immediate release and extended release in the same capsule, and have 100% efficacy on that drug. It's a branded medicine.
She tried the RightRe and it wouldn't work for her. 1 or 2 days we had to go right back to Cinnamon, and now we're back on generic.
Yeah, so many times, the problem with RightRe is that it's hard to switch over, especially if you're an advanced patient. And especially if you're seeing a general neurologist, they don't realize that the table that Amneal gives you to switch over the patient is underdosed, that you basically have to double it and then cut it in 4 to give the patient the adequate trial. And it takes some titration to get the right dose. The other option for patients is Duopa. So patients who have DBS and Duopa do the best because they have continuous tone. The electricity, the DBS is working 24/7, and your DBS is giving you continuous levodopa throughout the period that your pump is on, so that you have less of those fluctuations throughout the day.
Thank you.
So Lori, you're up. Hopefully you didn't wait so long that you forgot your question. I'll go ahead and unmute you and then go ahead.
First of all, I want to say hi to Debbie Shapiro in Israel. I don't know if she remembers me, but we talked years ago when she got her program started. I'm from the East Coast, from near Philadelphia. And my question is, if you have DBS, which I do you still get off times? I mean, I get very mild off time.
Yeah, so DBS, or deep brain stimulation, works very well for tremor, especially tremor we can't control with medication. If you have on time with dyskinesia, so every time you take a dose of Sinemet, you get dyskinetic or wiggly, you have involuntary movements. The DBS allows you to have on time without dyskinesia, and it increases your on time. So it doesn't eliminate the need for medication the way Duopa does, but it makes that on time last longer. So you'll still have on and offs, the wearing off, but they'll be farther apart. They'll spread out a little bit, but you will still have off periods. The same thing with Duopa, even though you're getting that continuous dose of levodopa, if you burn through it faster, you're doing your rock steady boxing, then you might need an extra dose. You have a button for the extra dose to give you that extra dose because you're wearing off a little bit earlier. So because we don't have a once a day levodopa, patients still experience off periods. We just want to make those few and far between.
Great, thank you.
Thanks, great question. And Dr. Ospina, Paul has a question before I chime in with mine. So Paul, you are now unmuted. Go ahead with your question, Paul.
I was listening to the discussion about generic carbidopa, levodopa, and that the variance of the 80% efficacy perhaps from the generic manufacturers. I go to Rocksteady Boxing, and we talk among all the patients, and we compared our pills. We saw 3 different shapes of pills. They're obviously coming from 3 different generic manufacturers. The one guy said he thinks the new generic he's getting from his drugstore that he used to get a different one isn't as effective. And that got me to thinking, can I sample around to various generic manufacturers to find one that is more effective for me? Does that make sense?
So you could do that. So Teva makes it, Mylan makes it, and some patients say, oh, I can only use Mylan, or some patients say I can only use Teva. So you just find the one that works the best for you, and then you just have your pharmacist order it for you. But you have to pay attention to who the manufacturer is and whether it worked well or not.
You've already taught me one thing I want to thank you for. I go to Rocksteady Boxing in the evening at 6:30. I'm on a 7, 11, 3, and 7 time frame. So I've actually been waiting and taking a pill midway through Rocksteady, right when I'm in a very heavy exercise period.
So I dose right before.
Yeah, well, near the end, when I start putting my gloves on, my tremors come in before I even get to start socking the heavy bag. Because I've been exercising so vigorously for the first half hour to hour before we start the beating on the fast bag.
Right, exactly. So you can dose beforehand, so you have a full gas tank to do all your exercise.
That's very helpful. I'll use that the next evening. Thank you.
Sure. So remember, Parkinson's medicine is very forgiving. Too little medicine, you're slow, stiff, and rigid, you're off. Too much medicine, you're dyskinetic or wiggly, you can or cannot hallucinate, but that goes away once the pill's metabolized. So we don't get too exercised if you forgot a dose or doubled up on a dose. Nothing terrible or permanent is going to happen. You don't have to run to the ER. You just wait for that dose to metabolize and the dyskinesia will go away.
And I love that saying, don't look at, treat the patient, not the clock, go by what you're feeling, what you're noticing, not, don't be a slave to that, 7 o'clock.
Right, exactly. So our goal, as a movement disorders neurologist, is to divorce you from the alarms on your phone and the clock. And so to get you on therapy where you're on most of the day and that you're not a slave to a schedule, like every 2 hours, the alarm on my phone is going off and I'm taking a dose of levodopa. We want to eliminate that as much as possible and give you more independence over your day and over your disease so that you're not always thinking about it and you're not always dosing during the day. So we get you longer acting forms of the medicine.
Very good, thanks. Okay, if no one else has a question, I have one. So Dr. Ospina, I know the peaks and the troughs that you're talking about, has there been research on whether having those very large, fluctuations from peak to trough, on the effect that long-term that has on the brain?
So there isn't any research, but imagine like if we were just turning off your light switch on and off all the time, that's not good for the light bulb. And that's what we're doing to your brain. We're turning your brain on and off every 2 to 3 hours. So it's not only the motor symptoms, your tremor, rigidity that's coming back. Remember, you have bradykinesia, slowness of movement, but you have Brady Friendly, slowness of thinking. So we're making that brain. So many patients say, they become socially isolated because they don't feel comfortable going out to dinner, going out with friends, because they feel like, oh, everybody else is talking, and then I can't jump into the conversation. I'm always way behind. So if you're off and you're Brady Friendly, that's like if you're on DSL and everybody else is on 5G. So it's one of the reasons why patients become socially isolated, the depression sets in, then the caregivers also becoming socially isolated, they're not going out. And so it's sort of a feedback loop on itself that we want to break and eliminate. And our goal is to get you out. Remember, there's 3 things that keep your brain young and healthy, physical exercise, being, intellectually stimulated, and socially connected. And so if you're not seeing your friends and family, you're staying at home, that brain, again, it's like a muscle, starts to shrink and, atrophy because we're not using it. So we need stimulus, and we need friends and family to be part of that stimulus. And if you don't feel like your brain is working fast enough to keep up with a dinner conversation, then you're not going to go out to dinner. So, it impacts not only, and that's how it impacts the patient, but also then the caregiver and the family. So it's important to make sure that we keep your brain on as much as possible.
Absolutely.
And I had another patient this morning where he said that, not only it was slow for him to like figure out things and think through things, but then it led to a lot of anxiety and frustration. And he's a patient who's taking levodopa every 2 hours, but is very, scared of considering DBS or Duopa. But he's like, yeah, but I'm like, you don't have any life otherwise, but he doesn't want to consider surgery or having a pump. So always we want to make sure with any therapy that the benefits of the medicine or therapy outweigh the side effects of the therapy, including to your pocketbook. But if you're off most of the day, you're not able to exercise, then maybe it's worth it to carry around a pump or have brain surgery so that you can get out and do things and maintain a job and all of those things. Stay on the 5G network.
Being on a 2-hour window, that sounds so difficult. So I have Mary.
Right, because most patients, they feel like, well, gosh, I'm not going to go out because I don't know if I'm going to make it back. Like, I don't know when my pills, yeah, exactly. When my pill's going to wear off, am I going to get dyskinetic? And so if with the oral medicines, you never know when the pill's going to kick in and how long it's going to last. And so then many patients say, well, I'm not going to go to church, or I'm not going to go to brunch because I don't know if I can get back.
Well, I have Marianne next. Marianne, are you there with your question?
Yes, it's more of an observation. I find that when I'm busy mentally, for instance, I've recently taken up very complicated jigsaw puzzles, and I'm finding that I get so involved in it that I forget the clock.
Mm-hmm.
Is that okay? In other words, instead of taking it at 12, maybe I won't even take it till 2, and that's when I start feeling it.
Right. So remember, we're treating your body, not the clock. So whenever it's your body that's wearing off, that's when we need to dose your body.
Okay.
Mm-hmm.
That's what I want to find out.
Early on, yeah. When you still have that 40% of cells that produce dopamine, when you take your Cinemet, your levodopa, you're able to absorb it and store it for later use. And so it's only the patients that at the end, where all of the dopamine is coming from the medication, they notice, wow, this pill really lasts only 90 minutes. As soon as the pill's metabolized, boom, I'm off. And I can't get back on unless I take another dose of medicine.
Okay, I find that when I get stressed over something, that it's shorter.
Shorter, right. So that's why early on, when we start you on medicine, you only need 1 tablet 3 times a day and you do just fine. And many times you miss that noon dose and you don't even notice. This is because you've absorbed that levodopa and stored it for future use. Because you still have those cells there that can that have the ability to do that. That's the reason we like you to exercise. Remember, all of the medicines that we have for Parkinson's disease are purely symptomatic. They just treat the symptoms of the disease. They don't stop or reverse the disease. We think that maybe physical exercise is the only thing that we know of today that may slow it down, because we're making those cells make new connections and hopefully they live longer. The longer they live, the slower the progression of the disease.
Okay, thank you.
Marianne, what kind of puzzles do you do? I can only get like 400 pieces, and then it's too hard for me. How big, how complex are you?
I'm finishing up a 500 piece that just about did me in.
And
but
how long did that take?
Well, I still have some more pieces to place, but I've been on it about a week. But I've just gotten back to doing jigsaw puzzles.
Okay, good.
And so I jumped in with both feet.
Good, yeah, exactly.
That sounds like one of those brain boosting activities like you were talking about, Dr. Ospina, right? Doctor approved jigsaw puzzles?
Doctor approved, yes. Remember, anything that makes your brain learn new things, so learning a new recipe, a new language, pottery, new skills, new hobbies, that makes your cell make new connections. And then that keeps it, it's like a muscle, it keeps it strong and healthy. If you don't use the muscle, it starts to atrophy and waste away. That we want that, to be intellectually stimulated and stimulate the brain so it learns new stuff and makes new connections. And that young and healthy.
We recently, my husband and I recently started chair yoga. Is this
That's very good.
Some exercise anyway?
Yeah, that's good. So chair yoga, Tai Chi is also very good for balance. All of those things are good things to do. Meditation, it helps with anxiety and depression.
And I think learning new things, learning new technology like Zoom where we are. I think a lot more people are asking questions live today than I have seen in the past. So bravo to everyone who's, maybe trying something new. Let's see. Kevin JD Mason had a question. Kevin, do you want to ask your question live? I will unmute you and you can ask it, or I could read it from the chat.
You can read it from the chat.
Sure. Okay, Dr. Ospina. The question is, he's wanted to clarify, are you saying that he should wait until he starts to go off before he takes his next dose?
No, I'm saying that you should not wait. You shouldn't be off before you take your next dose. So ideally, we like to dose you before you wear off. So that's why we have you on 3 times or 4 times a day. So we're dosing right before you start to taper off. And so it doesn't take so long to kick in. But if you start to notice wearing off, and then that could be non-motor symptoms like anxiety, paresthesias like numbness or tingling, depression, having a panic attack, then we want to dose right when you first feel the signs of wearing off so that you're not off so much during the day, because then you get these dose failures and then the next dose doesn't kick in as well and you're always trying to play catch up. So ideally your doctor's going to dose you whether it's 4 or 5 times a day or using longer acting forms of the medicine so that you have less wearing off during the day.
Does that answer your question?
Our goal is not to have off periods during the day, but that's very difficult with the current medications we have, unless you're on like DBS and Duopa. If you're taking oral medicines, because you have gastroparesis or that slowed gut, and because most PD patients have constipation, we're always going to run into a dose that has a delayed on because it sat in the stomach for too long, or a dose failure where it didn't kick in at all because we're at the mercy of the gut. So once we can bypass the gut, whether we use a pump or a patch or DBS, then we will have less trouble with the gastroparesis and less trouble with the delayed on.
Okay, I have another question from the chat that I'll just read, and this might be one, you tell me, Dr. Ospina, if you can't answer without seeing the, someone's chart. So she says, I have a question about RightRe. How long can you stay on RightRe, and can each prescription contain different combinations of ER and CR?
So RightRe are capsules of carbidopa levodopa, and each capsule has a third of the capsule is immediate release Sinemet, carbidopa levodopa, and then the other 2/3 of the capsule is extended release. And so that over time, so once we get that capsule into the small intestine, then it sits there and it absorbs that extended release a little bit longer. So in theory, it should last 4 to 6 hours. And your RightRe comes in 4 different strengths. So there's 95s, 145s, 195s, and 245s. And we can use any combination of those capsules to get you the dose that you need. So it's one of the reasons that titrating or switching over to RightRe takes a little bit longer, because we have to play around with the dose to get the dose just right. But once we get your dose right, you'll find that it lasts longer than your yellow Sinemet. So that yellow Sinemet never lasts more than 3 hours unless you're very early. And then if you're advanced PD, it could last as little as 90 minutes. So that we have a lot of flexibility with the RightRe about your dose and strength of the capsule. And we can use 1 capsule or up to 5 capsules at one time. So that's the other thing, that patients get switched over to RightRe and they're like, oh, I think my doctor overdosed me because my prescription says 3 capsules 3 times a day. That's 12 pills. I'm used to just taking 1 pill at a time. In RightRe, many times your dose is 3 capsules at a time. So that you're not being overdosed. It's just the way, if we gave it to your neurologist 1 big capsule, it would be too big to swallow.
Got it. And there was a clarifying question, the difference between the RightRe CR and ER?
Yep, so CR and ER are the same thing. So CR, many patients, it's supposed to be continuous release. Many patients say, it stands for crummy release because it just sits in the tummy. And ER, extended release, it's the same thing, it's just made by different manufacturers. So Sinemet CR doesn't exist anymore. Merck doesn't make it anymore. It's just extended release. But many patients say, oh, it stands for crummy release. And today we use very little Sinemet CR. We try to switch over to RightRe, which is a much longer acting form of the medication.
Okay, I have a question. So you mentioned your one patient who can tell he's about to go off, the anxiety and those non-motor symptoms. In that list that you prepared, there were some other ones that I'd never heard of and just wanted to see, like, for example, you said stuttering. Like, how might that be how is that even connected, and how might that be a sign? What was that patient's story?
Yeah, so just you can have like freezing of gait, and you can have a stuttering gait or festinating gait. So you have those short little shuffling steps. The same thing happens with the brain. It just sort of shuts down, it slows down, and you can have stuttering of speech as well. Or you can have word finding difficulty. All of those things can be part of your wearing off. So it's what Brady Friendly is, that slowness of thinking. Everything slows down, so it takes longer to process the information. You were able to do the tip on the, your breakfast menu, but then you were off in the lunch, you can't figure out your, 20% tip. It's because you have Brady Friendly and it's slowed down. Or the same thing where, you're trying to get into your computer and you can't remember your password, or it doesn't look familiar. It's because the brain has slowed down and the ability to process information has become impaired. It's slowed down.
Makes sense.
So just like you have stuttering of the gait, you can have stuttering of speech.
Well, absolutely.
Or freezing. So the freezing not only happens in freezing of gait, but freezing with your hands. You patients say, I don't have the fine motor coordination I did during my on periods. It's harder to manipulate things, or it's harder to write. The same thing.
Do you recommend to your patients to journal or keep track of those off periods or anything like that? Or is it just varies too much from day to day?
So no, we actually, we use medicine journals and medicine trackers because in Parkinson's, everything's more complicated. So like we were talking about dyskinesia. So we can have peak dose dyskinesia, which means too much medicine. So you take your dose at 8 and then by 10 o'clock you're wiggly. That's called peak dose dyskinesia. But you can also have diphasic dyskinesia. So as your medicine is wearing off, you become dyskinetic. Not only can you have a tremor, but you can have dyskinesia. So for us to figure out, is it peak dose or end of dose, we have to figure out when you took the medicine and when you had the symptoms. And then we figure out which one it is, and then the treatment is different. So let's say you had peak dose dyskinesia and you were taking 2 tablets of Sinemet 4 times a day. Then we could do 1.5 tablets, so you don't peak quite as much, so you have less dyskinesia, but now your medicine is going to wear off faster, so we're going to have to take it closer together. So if you're taking it every 4 hours, we're going to have to make it every 3 hours so that we keep you more like this instead of going up and down. And then if you take your dose at 8 and your dyskinesia doesn't start until 11:30, then we're like, oh, you have diphasic dyskinesia, then we need to take your dose closer together. So your 2 tablets closer together. The same thing happens with dystonia. So dystonia means an abnormal contraction of a muscle. Usually patients are dystonic at the end of the dose. The medicines wore off, so your big toe goes up, your toes cramp up, your foot turns in. And that's because your medicine has worn off, but you can have peak dose dystonia. So we have to, that's why your doctor's always asking you what time of day you're taking your medicine and how many doses or milligrams of the medicine you're taking, because we're trying to play Sherlock Holmes to figure out what's happening. So yeah, medicine trackers, we use them all of the time.
Okay, very good. And Tom, I think you were raising your hand because you had a question. Go ahead, Tom. We're doing the thing where you unlock the car door and then lock it at the same time. So I'm going to stop unmuting you and let you unmute yourself. Nope. Okay, Rebecca, if you could try to troubleshoot why Tom can't.
Hear me now?
No, there you go.
Okay. Yeah, my wife, before she had DBS and after, she always had trouble sleeping.
Yes.
And finally, we put her on melatonin 1 milligram a day, and that made a difference in night and day where she's able to sleep with trouble at night. I was wondering if, if other people would always was having trouble sleeping with any of her problems. Because like I say, that's why she had DBS. She never had the tremors. Her thing was that they kept giving her more and more and more medicine is one reason they recommended a DBS.
Yes. So the sleeping is part of the non-motor symptoms of Parkinson's disease. So sleep is affected in various ways in Parkinson's. So you can have restless legs. So every time you lie down and you want to fall asleep, your legs say, hey, no, I need to get up and walk around. So that's called restless leg syndrome. And we can treat that with a small dose of a dopamine agonist or a little bit more Sinemet or levodopa. You can have RBD or REM sleep behavior disorder, so that when you go to sleep and you go to REM sleep, usually you're paralyzed so that you don't act out your dreams. But in Parkinson's disease, that paralysis doesn't take place. So you can talk, yell, scream, kick, and punch, and you act out your dreams. And usually that keeps your bed partner up rather than the patient, but the patient can fall out of bed, hit the lamp, that sort of thing. And that can interrupt sleep. And we can treat that with melatonin over the counter or with some clonazepam at night. And many times RBD is present many years, sometimes decades before your diagnosis of Parkinson's disease. Before you get a tremor, rigidity, or you ever see a neurologist, you've had this talking in your sleep. And then you have a central form of sleep apnea where you're running out of oxygen, and then we figure that out. We diagnose that with a sleep study, and then we use CPAP or BiPAP to give you more oxygen throughout the night so you can sleep better. And then you can have sleep fragmentation that happens from the Parkinson's disease. So as your levels of dopamine go down, you're not going through your stages of sleep the way you should, and you wake up and you can't fall asleep. So that what happens is, your levels of dopamine go low, your muscles get rigid and stiff, you wake up, you have back pain, maybe some calf pain, you go to the bathroom, come back, and your body can't relax enough to fall asleep. And so it needs more dopamine to go through the stages of sleep and stay asleep longer instead of waking up every 2 hours. And the DBS allows you to have better sleep or longer sleep. And remember that sleep is very important in Parkinson's disease. Why is it that we spend a third of our life asleep? Something important must be happening, or why do we spend so much time asleep? And when you're sleeping, especially stage 3 and 4 sleep, the deep sleep, that's when your short-term memory is turning into long-term memory. You're consolidating all of those memories, you're learning more stuff, your brain is also cleaning up what's going on in the cells. So remember, what happens in Parkinson's disease is that there's a protein called alpha-synuclein that misfolds, and then it doesn't work correctly, and it also can't be cleared from the cell correctly. So the body forms a little Lewy body and sticks it into that little trash can. And what happens in sleep is that's when the garbage guy comes in and cleans up all of the debris from the cell, so the cell can act more efficiently the next day. And so the more we can clear up that misfolded alpha-synuclein, the better the brain is, the less neurodegenerative diseases you have. So it's important to get good sleep. And you don't all have to get all of that sleep at night. You can get it throughout your 24-hour day, so it's okay to take a nap. But that's why sleep is fragmented in Parkinson's disease. And another reason why your doctor uses longer acting forms of the medicine so that you're not wearing off. You know, usually we're dosing you with levodopa during the day, but nothing at night. But you still have Parkinson's at night. And so that's why you take your dose at 9 p.m. and then you wake up at 3 a.m. because you've run out of dopamine. And then we either have to dose you again or switch you to a once-a-day dopamine agonist or a once-a-day medicine so that we are getting you better coverage at night. And DBS, although we never say this because DBS really helps the motor symptoms of PD, it does help patients with sleep and they do sleep better. The same with Duopa.
Very good. Well, we're coming up on the end of the hour. I think what I wrote down is, I love what you said, Dr. Ospina, that, you know, when the medication is right and your off time is minimized, then you can exercise, then you can socialize, then we can keep our brains healthy, we can, you know, go out with friends, and do all the things that, you know, research has proven help keeps our brain, I think you called it nice and squishy. So I'll use your term. So I think that's a great angle of, you know, figuring out the medication with your doctor so you can live better. So do you have any closing words on wearing off and off time to leave us with?
So remember, our goal is to have the least amount of off time throughout the day as we can. So we want to eliminate it as much as possible. And if you're on oral medication, then that means we want those oral medicines to work as efficiently as possible. And if they're going through the gut, we have to make sure that we're treating the constipation so that your gut is moving and that medicine is transiting from the stomach into the small intestine in a timely manner so it can be absorbed. So it's really important to treat the constipation so that your medicines, especially if they're oral medicines, they're working efficiently. Otherwise, you know, we're just taking the medicine, you know, closer and closer together and everything getting stuck in the stomach and you have that delayed on. So one more reason to treat the constipation in Parkinson's disease.
Drink your water, eat your fiber.
Exactly.
Absolutely. Sometimes so you have years and years of medical training and fellowship, and it comes down to, you know, eat your veggies and drink your water.
Exactly. It basically comes down to everything you need to learn to treat Parkinson's you learn in kindergarten. Eat your vegetables, exercise, go out to recess, play nice with others, and take a nap. And drink your juice box.
When you break it down like that, not to oversimplify, you know, we so appreciate, and obvious the way that you handled all these questions from all different parts of the country and the globe. You know, thank you so much for sharing your clinical expertise with us. We really appreciate it. And so that concludes Lunch with Docs PD for today. Thank you guys.
Or midnight snack, depending on where you are.
Yes, or midnight snack with docs. So hopefully we learned something, we connected, you know, had some internet computer eye contact with everyone out there in the Zoom boxes, and we really appreciate everyone joining in, and thank you, Dr. Ospina, for leading the discussion.
Sure, anytime. I'm sorry I was late.
Oh, no worries. Okay, we hope to see everyone next month, every fourth Wednesday of the month. It's a date. We'll see you back here.
Take care. Bye-bye.
Thank you very much.
Bye now.